surgery. So why this topic at all? I think we've understood that olecranon fracture is no more only tension band wiring, and elbow dislocation is no more plaster for 3 weeks, and radial head fracture is no more a radial head excision. So elbow understanding is evolving. I think that's one part of it, and the other part is the patient and the surgeon is pushing the levels of outcomes which can be achieved in elbow related issues. So we've already evolved a lot in the last maybe decade. As in the morning lecture it was said that during Mason's time it was radial head excision, but now it is almost said that even if you are not able to get a good alignment, you maintain it for the bony integrity, the length of the forearm. So the newer possibilities in elbow surgeries are coming every day, and I'm sure in the next 5 years we're going to see a lot of changes. We are already sitting on many changes which probably has not reached our practice for various reasons. Things which have really helped us in our understanding is definitely the anatomy, the pathophysiology of the injuries and the diseases, and also the imaging possibilities. You can see that dynamic digital radiography, which is a possibility, and it's an excellent tool in evaluating instability, bony blocks and loose bodies and various other things. On the right you can see a figure which suggests that motion analysis is a reality now, and it doesn't, gait labs are not only limited to the lower limb and the cerebral palsy evaluation. If you go into the sportsman evaluation of the motion analysis, which is actually an extension of clinical examination, is a very important tool. Now these tools are adding to the understanding of anatomy and the pathophysiology of disease, and trying to make newer diagnoses and give solutions so that we can give a better outcome. So I'm going to take you through maybe 5 or 6 newer possibilities which will probably become reality in near future. So this is a very recent paper which talks about intraoperative 3D imaging in treatment of elbow fractures. Now, those of you who are working with a common C-arm with the cardiologist or a urologist, most of them have a DSA facility, and most of them would have a possibility of 3D assessment if you ask the company rep to install the software. Actually, the software is also there. You need to sort of get it running. So you need to ask your company guys whether you have this in your C-arm. We have it in our institute, although we didn't use it for 10 years. The reason was probably for a 3D scanning intraop, you need a radiolucent table. So invariably for the spine and the lower limb, you don't end up using it. But elbow can be taken outside the table, and most of your elbow side tables are translucent. So the 3D scanning actually gives you such pictures which are looking like CT scan pictures. What it does, it takes multiple shots at the setting you put, 5 degree or 10 degree. It takes say a minute or so to do it. It goes all around, and then the software reconstructs the image, creates a 3D, and from the 3D you can do a reverse planning and get 2Ds. So for minute issues like a step in the radial head, which you might not be able to assess otherwise, it gives an amazing sort of an information to maybe address it and not end up in a stiff elbow and have to come back later on for a revision surgery. So that is what they concluded in this paper, saying that if you are able to assess this, the possibility of revision surgeries and better outcomes is more. So go back and look at your C-arms. You'll be surprised you might be having the facilities. And the teams who are doing spine in their units, they actually have O-arms in their OT. So why are we not using the O-arm to assess our reductions for elbow? I'm surprised. So let's move further. Once we have a CT scan, you can really play around with it. So the CT scans for the elbow, the wrist, and most of the extremity has this problem. They will start scanning from maybe mid-arm, and then they will give you a 1 centimeter cut, and the area of interest will have 2 cuts. And you will be struggling to understand despite having your CT scans. So a small change in behavior, please specify that you need 0.6 mm cuts of a region which is within 3 maybe inches from the joint, so that you get to know what you want to know. Once you've done that, then you can actually use softwares which are free source softwares and create your fractures in such a way. You have free sources to create plates, to create screws, and plan out whatever you want to do. So you are more aware and awake about the problem which you are dealing with. And if you have a real complex problem like a malunion which we were talking in the morning, and you really want to assess it, a simple thing is to get a CT of the opposite side itself. So elbow is a great joint because you have the template on the normal side. So you get a CT of the opposite side and you mirror it, and you can map it with your fracture and understand the fracture more beautifully. And in complex problems, it becomes a boon. Third thing, so with the same CT scan, you can understand the pathology, as I've told you before. But then, like in this example, this is 2023, it's a case report, and it's a aggressive tumor of the distal humerus with a pathological fracture, responding to chemotherapy and now asking for reconstruction. So now if you have to give a reconstruction and you can assess the tumor using the same CT scans, the same CT scans can be helping you in designing customized solutions. And what they've done here is a distal humeral reconstruction and replacement, meaning they have not gone into the ulna, they have not produced a hinge joint over there. They've just replaced the distal humerus with possibilities of anchoring back all the tissues which are allowable oncologically. These customized solutions are now possible in our country also. It's not rocket science. They're all based on CT scans, they are based on what you plan, and they're based on the normal side of the opposite side. So that's what. So once you go into the current concept publications in world literature, you'll be surprised that pure distal humerus replacement is going on for over 10 years now. And this another thing, long-term results of lateral resurfacing elbow arthroplasty. It's also called the uni elbow. So there would be indications like arthritis or post-traumatic stiffness or many other things which where you feel that the humero-ulnar joint doesn't have any issue at all, and everything which is creating a problem is on the lateral side. So the paper itself says long term, and the average follow-up is 8.3 years. So it's not future possibilities, it's already there. And Stryker makes this, and there are many other companies which make this. So this is 2023. This is a meta-analysis. This is a systematic review on radiocapitular arthroplasty. A very interesting paper if you just Google. And the journal is actually Journal of Shoulder and Elbow Arthroplasty. So we're getting specific journals for upper limb, and it says that it's probably a viable option. And then you can have peculiar problems, and you can have customized solutions in future. Like this is a very, very complex open fracture which went through many operative procedures. It's a 2022 paper, and they've used the Masquelet technique initially to manage the open fracture, and then they've gone around to give a customized solution because there was actually nothing left. And you can create your joint as well as your guiding jigs, which will ensure absolute appropriate stability. And then this is a indication which you will actually judge and maybe post according to your clinical judgment. If you have a patient with ulnar neuritis and there are osteophytes sitting there, and you clinically judge that it is because of that, it's not very difficult to make a judgment. But then if there are issues related to the ulnar gutter, and they could be picked up by a CT scan, but to say whether it's a normal or an abnormal thing, I think the opposite elbow template is a beautiful thing. And when you overlap it, you get to know, you see, you need to address it. If you deepen the tunnel and address the irritation, the problem is solved. You can create a prototype of the elbow itself, and you can actually create a prototype to guide the burring out of the extra bone which is there. And you can have both sort of jigs. One jig to evaluate how much you need to dig, just 1 minute more, and the other jig to see whether the process is complete or not. And then Dr. Vinod's last line of his talk on elbow arthroscopy talked about AI, navigation and robotic in elbow arthroscopy. Now this is futuristic. This talks about augmented reality enhanced elbow arthroscopy. What it means is if you have a CT and a MR of a patient which is high resolution, you can actually create a real-time model of that, and that can actually be projected over the patient. So the meaning of this is that when you're doing elbow arthroscopy with a held device and you switch it on, you can actually see the ulnar, median and the radial nerves. So imagine how easy it becomes to create the portals and direct them towards the radial head as he suggested. So it really enhances your ability to execute an answer. This is still an experimental phase, but it's not far that it will come into real life. And the final thing, COVID has taught us to execute remotely, and the maximum solutions which have come on remote execution is on rehab. Taking care of the backaches and the neck pains. They could the rehab expert could remotely address the patient through it. Now these are equipments, the virtual reality equipments, which the patient can wear, and he would get to know through the virtual reality equipment that how much he's supposed to do, and how much he's done, and how much more he has to do. And at the same time, the rehab guy can connect to him and get the exact progress. So it gives the ability of guidance as well as supervision. And then VR is an excellent tool on training. So all the training which normally happens either on sawbone or cadaver, they have the limitation. Sawbone once cut is gone, cadaver once cut is gone. A VR, you can use it a million times, you can use it at the middle of the night, and it is reusable. And you can actually import the real anatomy of a patient. Futuristic things, these are going to be realistic. Already the anatomy dissection tables of the high-end institutes are virtual. And one last experience which we have used and published in the American Journal a few years back was a deformity correction. Dr. Lalit is doing a lot of work in pediatric deformity correction, and he is going to come out with a paper on what more is existent in genu valgum, meaning that rotational malalignments and oblique plane malalignments you cannot pick up on AP and lateral views. However, if you get a CT scan done and you do a modeling, and if you can overlap it on the normal side, you can understand that there is a rotational malalignment also, and it can be very easily executed by creating customized jigs. So friends, when you have exhausted all possibilities, remember this, you haven't. So I hope I have introduced few newer possibilities in elbow surgery, and 3 years down the line, maybe we'll have case series of all these being presented. Thank you very much.